Looking at leukocytosis, we have lots of different potential causes ranging from infection to leukemic neoplasias or other malignancies and even trauma, stress, and or hemorrhage. You also can see that tissue necrosis or inflammation can lead to an elevation in white cell counts, as well as dehydration due to hemoconcentration, which leads to an increase. Thyroid hormones can increase white blood cells as well as steroid use. Moving over to leukopenia. Leukopenia, we can go and see that there are also a wide variety of causes, ranging from drug toxicity, bone marrow failure, infections, dietary deficiencies, issues with our spleen being too aggressively extracting white blood cells from the blood, even autoimmune disease and infection all can lead to a low white blood cell count or leukopenia. Looking at some kind of patterns, when we have a bacterial infection, we tend to see a larger increase in white blood cells and neutrophils in relationship to the others. We can also see some immature neutrophils present. Steroid therapy, we can see increase in white blood cells and neutrophils versus splenectomy. We see that just that white blood cell count, but no changes in diff. Viral infection, our white blood cell count could go down. In chemo, we can see it going down pretty significantly with also an increase in monocytes. Looking at our neutrophils, we can see neutrophilia and neutropenia. In neutrophilia, this is an acute suppurative infection or Cushing syndrome or other inflammatory disorders. Some metabolic disorders can lead to high amounts of neutrophils, as well as other variety of disorders and even physical or emotional stressors and trauma. Versus neutropenia, we see things ranging from Addison's disease, not addition, Addison's disease. We can see aplastic anemias or dietary deficiencies, certain drugs, and of course, certain infections that maybe overwhelm an elderly individual could lower neutrophils. Radiation exposure and some viral infections actually can lower our neutrophil count. This is what our neutrophils would look like histologically. We can see that kind of different nuclei that has the different lobes. One thing to remember is with neutrophils, we have something called toxic granulation that can occur, and this is a severe inflammatory response. The toxic granules that are staining much darker, this is often due to impaired cytoplasmic maturation because the bone marrow is trying to generate a large number of granulocytes relatively quickly. Hypersegmented neutrophils look like this. We see many more lobes. If you see more than three of these cells if with per 100 in a high power field, or if you have evidence of any of these cells that have six lobes or more, that would be evidence of hypersegmentation. Lymphocytosis or lymphocytopenia, so our T's and B's, natural killer cells, if we see an increase in these, we can see that with a chronic bacterial infection. We could also see this with some viral infections like hepatitis or mono. Certain cancers like leukemias, lymphocytic leukemias, or even multiple myeloma, treatments like radiation or just radiation exposure, and even viral infections such as mumps and rubella. Versus lowering of our T's and B's and natural killer cells, we can see that with certain drugs or medications in an immunodeficient state or disease, and for example, HIV in its later stages. Leukemia and lupus, radiation therapy, and sepsis can lead to a lower count of our T's and our B's. And this is an example of a lymphocyte histologically. We also see some teardrop cells here, it looks like. But this, we can see this very large nucleus with not a lot of cytoplasm. Looking here, we can see an atypical lymphocyte. We see kind of an amorphous shape. It's much larger, and then the nucleus is almost kidney bean shaped instead of kind of filling the whole space. Monocytes typically are going to be increased in a chronic inflammatory disorder or chronic ulcerative colitis. Also, parasites like malaria and tuberculosis, as well as mono and other viral infections. Aplastic anemias, drugs like prednisone and hairy cell leukemia can lower monocyte counts. And this is our monocyte. It's a true kidney bean form, and we can see it has more cytoplasm present than in our lymphocyte cell. Our eosinophils are typically raised with allergic, autoimmune, or parasitic infections. Eczema or leukemia also could show an increase in eosinophils. Decreased eosinophils, there's not many things, but we can see when we increase our adrenosteroid production that our eosinophil production can decrease. This is what an eosinophil looks like. It kind of has similar nuclei lobes to a neutrophil, but its granules stain orange or red typically. Our basophils can be increased with leukemia or some myeloproliferative disorders or diseases, and they're decreased often in acute allergic reactions, hyperthyroidism, or even stress. Mast cells and basophils often get confused for one another, so it's important to kind of pull or divide them and conquer. Mast cells mature in connective tissue versus basophils in the bone marrow. Mast cells can live for months versus basophil days. And mast cells are in the tissue, which is why we're not measuring them via blood, versus basophils live in our circulation. We can kind of see the developmental process of some of these different cell lineages here in this image. When we come back, we'll look at white blood cell development and maturation in words, and then we will also look at some of the common responses that we see to infection and kind of how we move through the stages of infection.